Hello, everybody, and welcome to Veterans and Parkinson's, a team approach to living well. My name is Annie Long, and I am an Associate Director of Community Programs for the Parkinson's Foundation. I am also the daughter of a Marine, the sister of a Marine, and the daughter-in-law of an Army Colonel. So it is an honor and a privilege to be able to bring you this program today. I want to first and foremost thank today's program sponsor. The Veterans and Parkinson's virtual programs are supported by a grant from Genentech, a member of the Roche Group. Here at the Parkinson's Foundation, our mission is to improve the lives of people living with Parkinson's through expert care and research. We are the nation's leading community for people living with Parkinson's, those who love them, and those who are working to end the disease. The 1 million Americans living with Parkinson's, including the more than 110,000 veterans living with Parkinson's, deserve the promise of a cure and a better life today. Here at the Parkinson's Foundation, one of our primary goals is to make sure that people living with Parkinson's and their family members have access to cutting-edge research, life-saving resources like our Aware and Care kits, and education. We provide education through our virtual webinars, through our in-person educational programs, through our publications like our books that cover a variety of Parkinson's-related topics, and so much more. I encourage you, if you haven't already done so, to please check out all of our resources on our website at parkinson.org. From there, you can access, again, podcasts, webinars, videos. You can search by topic, and you can actually visit a special section of the website for veterans by going to parkinson.org/veterans. So as you can see here on the screen, the Parkinson's Foundation and the U.S. Department of Veterans Affairs has formed an official partnership. And the goal of that partnership is to make sure that veterans with Parkinson's and their family members have access to information to help them live well with Parkinson's. From parkinson.org/veterans, you can access information on medical care and treatment, Agent Orange and other toxic exposures, veterans benefits, and information for care partners of those living with Parkinson's. We also have a fantastic FAQ book that you can download from that webpage. So before we get started, I want to again highlight a couple of other events that we have coming up for our veterans. Understanding Parkinson's disease and mental health in the veteran community will be hosted online via Zoom on April 28th. We will try to get a link to these events in the chat here in just a moment. And then Veterans and Parkinson's Mobility and Driving Safety will be taking place on Tuesday, June 21st. So we encourage you to check out these webinars. Of course, our programs are free and open to all. We just ask that you pre-register in advance of the events. And in response to the changes that came with COVID-19, we pivoted very quickly from in-person educational programs to offering lots of online content for our Parkinson's community. And we do that through PD Health at Home. PD Health at Home is our virtual program series. Every Monday, you can visit us online for Mindfulness Mondays, led by my colleague, Krista, where you can work on meditation and relaxation techniques. We also have Wellness Wednesdays, where we cover a variety of topics and hear from expert speakers all over the country. And then, of course, Fitness Fridays. With Parkinson's, exercise is of the utmost importance. So we encourage you, if you are not already doing so, to please find an exercise program that works for you. You can join us every single Friday. We actually have on-demand fitness classes on our website. And then once a month, we actually have a live fitness class via Zoom, led by Parkinson's instructors from, again, all over the country. So we encourage you to get more information about PD Health at Home by visiting parkinson.org/pdhealth. All right, and if those of you who have Parkinson's, a confirmed diagnosis of Parkinson's, we encourage you to participate in PD Generation. PD Generation is the Parkinson's Foundation newest genetics initiative. It's the first of its kind, and it's on a national scale. But through PD Generation, if you have a confirmed diagnosis of Parkinson's, you can access genetic testing for clinically relevant Parkinson's related genes and counseling at no cost to you. Counseling is also available, and not only in English, but also in Spanish. So one of the goals of PD generation is, of course, to uncover what is responsible for slowing or stopping the progression of Parkinson's. You can either participate in person at one of our participating centers of excellence. You can also order an at-home cheek swab test kit and do it from the comfort of home. So we are trying to get 15,000 people to participate in this genetics initiative and need your help. So please consider joining us. You can get more information and sign up for a consenting appointment at parkinson.org/pdgeneration. All right, well, without further ado, I want to make sure again that I highlight two of our amazing resources, our website, parkinson.org, as well as our toll-free Parkinson's Foundation helpline. For any of you that have questions about your Parkinson's, about symptoms, about treatment options, our toll-free helpline is staffed by nurses and social workers who are expertly trained in Parkinson's and ready to take your call and answer your questions. So we encourage you to give them a call. You can also call them to order any of our free resources as well. So now, without further ado, it's my pleasure to introduce our first speaker for today, Dr. Danielle Shpiner, who is an assistant professor of clinical neurology and a member of the Division of Parkinson's disease and movement disorders at the University of Miami Miller School of Medicine. Dr. Shpiner also serves as co-medical director for the University of Miami Parkinson's Foundation Center of Excellence and as the movement disorders neurologist at the Bruce W. Carter VA Medical Center. So Dr. Shpiner, we are very excited to have you here today and look forward to your presentation. As a reminder, during Dr. Shpiner's presentation, you will have the opportunity to submit your questions via the Q&A icon at the bottom of your viewing page. Please take advantage of that, submit your questions, and we will get to as many of them as we can following Dr. Shpiner's presentation. So Dr. Shpiner, take it away.
Hi, everybody. Thanks, Annie. I'm so honored to have been asked to talk with you today about building your Parkinson's care team. Okay, so as Annie mentioned, so who am I, just to start out with? So I'm the movement disorders neurologist at the Bruce W. Carter Miami VA Medical Center. I'm also an assistant professor of neurology at University of Miami across the street. And I also am the medical co-director of the Parkinson's Foundation Center of Excellence at University of Miami. And recently I became the director of our brand new Parkinson's disease multidisciplinary clinic at the University of Miami. So the concept of building a care team and interdisciplinary care is really near and dear to my heart and a very central part of what I currently do. So I just want to start out by highlighting the fact that most experts in the field agree that the ideal Parkinson care is interdisciplinary, meaning that it involves multiple disciplines working together in an integrated way to provide care for the patient. And we're going to talk a little bit about more in detail about what that means today. So just to start out, I think most people here probably already know that Parkinson's is a complicated disease that can come with many different kinds of symptoms. So that can include both motor symptoms, by which I mean movement problems like stiffness, slowness, walking problems, balance problems, tremors, dyskinesias, dystonias. These all fall under the category of motor symptoms. But Parkinson's can also come with a lot of non-motor symptoms, meaning things that have nothing to do with movement problems, things like memory problems, mood problems, constipation, problems with sleep, hallucinations, lightheadedness, pain, loss of smell or taste, sexual problems, urinary problems, weight loss, fatigue. The list really goes on and on. And the other important thing I think to keep in mind is that each patient is really unique. So, I know it can be very overwhelming sometimes for patients to read about symptoms of Parkinson's, and maybe you even feel overwhelmed hearing me mention this whole list, but keep in mind that not every patient is going to have every problem on this list. And one of my favorite quotes actually that I think about a lot with regards to this topic is one of my Parkinson patients once told me, If you've met one patient with Parkinson's, you've met one patient with Parkinson's, meaning that each patient is completely unique in terms of what symptoms they experience and what needs they might have in terms of their treatment. So I'm going to just talk now one by one through a bunch of different people that may make up an important component of your care team. And then we're going to talk at the end about how to put this all together. So the first person I'm going to start with is the movement disorder specialist. So this is a neurologist who specializes in treating Parkinson's and other movement problems. So this person has completed 4 years of college, 4 years of medical school, 4 years of neurology residency, learning how to be a neurologist, and then 1 or 2 additional years of movement disorder fellowship training where they focused 100% of their time on learning how to diagnose and treat patients with movement disorders. So this person is really going to be the expert in diagnosing Parkinson's and treating the associated motor symptoms. And probably they're also going to be quite good at treating a lot of the non-motor symptoms. And this person also is going to be an expert at determining if you might be a candidate for advanced therapies like deep brain stimulation, and probably is also going to be the person who's going to be in charge of programming your deep brain stimulation or managing your advanced therapy for Parkinson's. This person is also probably very experienced at recognizing the time and the need to bring on additional members of the care team to help manage your symptoms. So if you have access to a movement disorders neurologist, they're a very good place to start in terms of your care team. So I want to highlight also here the role of general neurologists. So these are neurologists who have experience treating a wide range of neurological problems. So this might be the first person that you see when you first notice your first symptom of Parkinson's or your first neurological symptom. They might be the person that first recognizes and diagnoses your Parkinson's, and they also might be the first person to initiate treatment. And depending on where you're located and what your access is to movement disorder specialists, this might be the primary doctor who manages your Parkinson's symptoms. And it may be like, for example, at our VA center, I'm currently the only movement disorder neurologist who's at my VA. And I only work here 1 day a week because I split my time also at the university. So for a lot of my patients, they may come to me initially when they're diagnosed because they want to learn more about their condition. They may come to me for a second opinion about their diagnosis, or they may come to me, intermittently as, maybe symptoms progress or become complicated. But in the meantime, they're going to follow regularly with their general neurologist who's going to, help them with the majority of their care. So this is, general neurologists also have a very important role to play in your overall care of Parkinson's. Okay, so moving on to the primary care doctors. So these are, I'm sure everyone on this call has one of these. So these are general doctors who have experience treating a wide range of medical diagnoses, and they're also experts at practicing preventative care. So this might be the first doctor that you see that suspects Parkinson's, and they may refer you to a neurologist who diagnoses you. This is by far going to be the best team member to coordinate recommendations of different specialists and direct your overall medical care. And this also is going to be your go-to doctor for the evaluation and treatment of many of the non-motor symptoms of Parkinson's. Okay, next is mental health providers. So this includes, I'm including in one slide here, psychiatrists and psychologists, but they're both very important and very different in terms of what kind of care they can provide. So a psychiatrist is a medical doctor who's an expert at treating mental health disorders and symptoms. And they can help prescribe medications to help with mental health symptoms related to Parkinson's, including depression, anxiety, and hallucinations. Psychologists are PhD educated health professionals who are experts in disorders of the mind. So some of them, depending on their skill set, may provide therapy to help with coping with difficult diagnoses or with mood symptoms in Parkinson's. A type of psychologist, a neuropsychologist, maybe you may be referred to one of these people to help assess your memory and cognition. And they're very often, you may also meet them if you're a DBS candidate, because they're often part of the team who evaluates the patient when we're considering whether or not they might be a good candidate for DBS or other advanced therapies. Okay, so there's many other doctors that you may also want or need to have on your team. So these can include neurosurgeons who often become involved in Parkinson's when it comes time to consider advanced therapies like deep brain stimulation. Urologists can be really helpful at managing urinary complaints or sexual dysfunction that can come with Parkinson's. Cardiologists often get involved when someone has a lot of trouble with orthostatic hypotension, meaning the lightheadedness or drops in blood pressure that many Parkinson patients can experience when they stand up. Gastroenterologists can sometimes get involved for patients who have severe constipation, gastric dysmotility, or other GI complaints. Sleep medicine specialists also can be an important part of the team for patients who have a lot of sleep problems related to their Parkinson's, including REM sleep behavior disorder. This is the symptom where the patient may have a lot of movements at night or acting out dreams or things like that. So these specialists are very experienced in diagnosing that problem and also offering options for treatment. And then palliative care specialists can also be an important part of the team. And this doesn't have to be just at the end of the disease, but palliative care specialists are experts at managing symptoms that are bothersome. So, and they can be helpful for managing many Parkinson's related complications. Okay, so nurses and nurse practitioners. So these are healthcare professionals that are trained to assist and support physicians in clinical practice. So you may encounter them at any and all of the doctor's appointments that I mentioned previously. So they may help conduct clinical assessments. They may refill medications, or maybe even if it's a nurse practitioner, recommend some changes to your medication doses or regimen. They often are the first person that might help answer questions about Parkinson's symptoms if you call your doctor's office. And they can also help coordinate recommendations from your other specialists within the other members of the Parkinson's team. Okay, physical therapists. So these are experts who are trained to work with you to regain and maintain mobility, which is of course super important in Parkinson's disease. They also can help you develop a feasible and enjoyable home exercise and wellness program, which is again super essential in the management of Parkinson's at any stage. And one thing that I also focus on a lot when I talk to my patients who have walking and balance problems is that these are some symptoms that sometimes respond to medicines in Parkinson's, but they don't always. There's some patients who it doesn't matter how much medicine you give them, it's not going to help with the walking or balance. And in those patients, really, the best treatment by far is referral to a physical therapist who can work with the patient on strategies to improve walking and balance. So I think physical therapy really has a role in Parkinson's at pretty much any and every stage of the disease. Okay, occupational therapists. So these are specialists that can help you meet the challenges that Parkinson's may present at home and at work by showing you ways to modify your environment and new ways to approach tasks, given the limitations that you might have. So they're trained to help you optimize your ability to perform any normal activities. So these include both activities of daily living. By this, we mean activities at home, like, preparing food for yourself, bathing, dressing, brushing your teeth, all of these kind of things. Also with activities of work, depending on what your profession is, play, education, leisure, and your social life, which is also super important. So they may also be very helpful at recommending assistive devices, or they can help you determine if a particular device might be helpful for you. Okay, speech therapists. So these are specialists at assessing speaking and swallowing problems, which are also important symptoms in Parkinson's disease that, again, sometimes don't respond well to medication. So a speech therapist is the person who's going to be able to best evaluate your communication or swallowing abilities. diagnose any underlying problems with those abilities, and help you develop a personal treatment plan, and sometimes provide therapy to help you improve. And again, the speech and swallow problems, unfortunately, are symptoms that are not very easy to treat with medications in Parkinson's disease. So really the best treatment for these kind of problems is working with a speech therapist. So I also work very closely with speech therapists when I take care of my Parkinson patients. Okay, moving on to social workers. So social workers are specialists who are trained to help with a wide variety of problems. So their initial assessment usually involves evaluating the patient and his or her family functioning, including patient and family members' emotional state, their perception of their disease and incurred losses, existence and use of social support, caregiver issues, which are also super important topic in Parkinson's, and family coping with the diagnosis, and also maybe changes that have happened to your life or lifestyle as a result of the diagnosis. Some social workers are trained in offering counseling services to individuals, couples, and families, so they're a good resource for that as well. And they also are experts at knowing what kind of resources are out there in the community. So they are the ones that can help link you to federal, state, and local services and other resources. And they also may be actively involved in running support groups, which is another really important part of Parkinson's disease management. Okay, so other healthcare professionals. So your Parkinson team may also include chaplains who can be helpful at providing spiritual
Hey, we're just going to try to get Dr. Shpiner back. I think
I'm back. I'm
you
sorry.
froze. Okay. No problem. Take your time.
Okay, my Wi-Fi cut out, but it seems to be back now. Can you see my screen?
Yes, we can.
Okay, perfect. Sorry about that interruption. I'll just jump right back in. So your Parkinson team can also include chaplains, which again can be helpful for helping you manage spiritual concerns regarding the diagnosis, your prognosis, change in lifestyle as a result of some of the symptoms that Parkinson brings. Dietitians can be really helpful, especially for patients that have swallowing problems or difficulties with weight loss or maintaining weight in Parkinson's. Pharmacists can be helpful in helping you manage medications, and especially I want to highlight I feel like that's one of the things that the VA does particularly well. I think the pharmacy department is very well integrated with the physicians at the VA. And I spend a lot of time when I'm here at the VA talking with pharmacists to kind of help come up with the best medication strategy for patients. Research coordinators can be helpful if, clinical trials are something that you're interested in, or you want to get involved in Parkinson research. You may work very closely with some research coordinators. Sex therapists can be also very helpful for some of the sexual problems that come with Parkinson's. And I actually found out recently that we used to have one as part of our multidisciplinary care at UM. Device reps can be helpful if you're a patient with DBS or other advanced therapies for Parkinson's. The ones that I've worked with are usually make themselves available to patients really 24/7 to be a resource for questions about how the device works or how you operate your patient controller, or, oh my gosh, I lost my medical alert card. Can I have a new one? So this is another person that's so often very helpful in terms of managing not only the advanced therapy, but they also tend to be very knowledgeable about Parkinson's in general. And then this list I want to highlight is by no means, exclusive. I think there's many other people that could be important parts of your healthcare team, depending on what your particular needs are. Okay, so moving away from the healthcare professionals for a minute, I just want to highlight the importance of care partners. So I think care partners are an essential part of any Parkinson's team. So these are the people that are going to be there to provide support as you kind of deal with some of the symptoms of your illness. So this could include spouses, siblings, parents, children, friends, neighbors. I have patients who, come to their appointment with their neighbor, who's the person who gives them a ride. So I think I just want to highlight that I definitely include care partners as part of the Parkinson team. And I think they're an integral part. It's very hard to manage this disease without them. Other Parkinson patients, I think, are another important source of support. And I think there's a lot of places where my patients have found other, a strong community in other Parkinson patients. So support groups are an obvious one, but sometimes exercise groups. I included a picture here of a group of patients participating in rock steady boxing. I feel like my patients are kind of all over the map with support groups. I have patients who really love them and patients that are like, I don't really like to just sit around and think about the symptoms of my disease. But those people some of them have found really good community in exercise groups, because it's a good opportunity to meet other people with Parkinson's and have another activity to focus on. And then I think especially, in the COVID age, I think online communities and online resources have really blossomed. And I think there's a lot of good online support groups and online Parkinson communities that can also be a really important source of support. I think sometimes it's important to be able to talk with people that understand exactly what are the symptoms that you're going through and the situation that you're in. And so I think other Parkinson patients are an important part of the care team for many patients. Okay, home health aides. So these are people who may be a good source of support in terms of helping with routine chores and activities of daily living at home that can sometimes, again, some activities can become difficult as a result of Parkinson's symptoms or fluctuation in symptoms, and home health aides can help fill that gap. So they can also help with medication management. I know sometimes medication regimens in Parkinson's can be very complex. It can be hard to remember to take medications on time, or, how to space them from meals, or, those type of things. And home health aides can be really helpful with medication management as well. They also, most of them, or they often may have some medical training, so they may be able to help monitor some of your symptoms, including, both physical and mental symptoms. So they may check your vital signs, if you're somebody who has a lot of difficulties, for example, with fluctuations in blood pressure. They may be able to monitor your exercise level or maybe assist you with certain exercises. They may also be able to help you monitor, your appetite, or your, how much you're eating or drinking, et cetera. And some of them also can be very good and helpful at recognizing and handling emergencies at home, and knowing when to call the doctor, knowing when to call 911, et cetera. So let's talk about how to build a team. So remember, I just want to highlight again that Parkinson's is a very complicated disease and each patient is unique, which means for me that each patient really has to develop his or her own team depending on what the needs are. And that may not be something that your team today may not be the same team that you need in 5 years and 10 years and 20 years. So you may need different things from different people on the list that I just mentioned at different times during your disease, and depending on what your symptoms are and what your unique situation is. So I know this really is a lot of information. I've just rattled off a long list of people that can be involved in your care. So how do you get started with this? So I think that your neurologist is a good place to start, because this person is really well equipped to discuss your symptoms with you and then decide together with you and maybe with your care partner what your needs are in terms of if it's something that you can kind of handle just with your neurologist, or if you may have some symptoms or needs that could benefit from referrals from other health professionals. I think it's also, a good time. It's always a good time to kind of practice a little bit of self-reflection, think about what your needs are, talk with your care partners about what your needs are, and then maybe come back to your neurologist or your primary care doctor or your social worker to discuss what resources might be available depending on your location to meet those particular needs. And then I just want to highlight again, I know Annie did, but I think the Parkinson Foundation is an amazing resource for patients. And I'm not just saying this because they asked me to speak today on their program, but this really is my number one go-to source of information for patients. I think it has a lot of good patient-friendly information kind of about Parkinson's, about resources. Parkinson Foundation also has their own support group resources for patients and care partners, which is important. And of course, I know Annie already highlighted it, but there's the special page of resources just for veterans that I refer many of my VA patients to. Okay, and on that note, I'm going to wrap it up, and I'm available for any questions that you might have.
Great. Thank you so much, Dr. Shpiner. That was a really thorough presentation. And so now we're going to get to a few questions that we've gotten. For those of you guys who are listening, please continue submitting your questions for Dr. Shpiner. We are also going to be taking questions after our expert panel. So if you have questions that are probably more closely aligned for an occupational therapist or a mental health professional, you can certainly save those questions for our expert panelists. But Dr. Shpiner, I want to go ahead and just ask you a few questions. And I know some of this you kind of covered, but just to sort of reinforce some of these more important points. How would you recommend a veteran with Parkinson's locate, a movement disorder specialist? Like you said, I think is starting with their general practitioner and neurologist the best place to start?
I think that's a really good place to start. I think I know also the Parkinson Foundation keeps a list of all of the centers of excellence and all the providers that you can search by like geographic location. So I think, between that and your general neurologist also is probably a good person to identify who are the movement disorder specialists in the area that they work with.
That's great. And I know, one of the things we work with the VA on is to, make sure people are aware of the PADRECs, which I believe there are 6 PADRECs across the country. And these are, VA centers that are, really experts in treating Parkinson's. And then there are also consortium centers as well. So if you're not near a PADREC, you might be near a consortium center. But I think, like you said, no matter where you are, I think it's really important just to be vocal and to talk to your family doctor and neurologist about your particular needs and work together to try to address them.
Absolutely. And then the other thing I want to highlight that I think has been a really big development since COVID, and one of probably the best things that I think has come out of the pandemic is the availability now of telemedicine. So it used to be that if you lived in a rural location or you lived in a remote location that was not close to a big city, the chance of being able to have access to a movement disorder specialist was really quite small, unless it might require hours of travel. It might require traveling to another city, staying overnight just to see a doctor. But nowadays, because of telemedicine, I'm able to see patients even that live hours away from our center on a fairly regular basis, actually. So I think that's been an amazing development that's dramatically improved access to care for a lot of people that maybe otherwise wouldn't have had access to a specialist.
And that's a great point. And I think people are a little skeptical, right, of telemedicine. They think they're going to get more benefit by going to see somebody in person. But it sounds like, to your point, maybe seeing a practitioner who's local, but then seeing a movement disorder specialist, via telemedicine would be a great option if you don't have one nearby, so that you're not spending hours in the car.
Definitely.
And how would somebody set up a telemedicine appointment with you, for example? Do they have to be in Florida, or how does that work through the VA system?
Yeah, so this is a little bit of a moving target. And I have to say that, throughout the last 2 years since we started with telemedicine, the rules have changed a lot. And honestly, I feel like every couple of months I hear like a new update and rule change. So whatever I say is definitely subject to change. But my understanding is that currently the rules are that you have to be physically in the same state as the doctor, so that you don't break rules in terms of practicing medicine out of state lines, unless you have a doctor who is licensed to practice in multiple states. The general rule is you have to be in the same state.
That's great. And I know we had quite a few questions both before today's program as well as during today's program about Parkinson's progression. And I know that is also, one of those things that's hard to address because everybody is so different. But, in general, for someone who's, say, newly diagnosed, what would you say is kind of the general prognosis? When you're seeing a veteran who's recently diagnosed with Parkinson's, what would you sort of tell him or her about, what they can expect to see?
Oh my gosh. So this is both like my favorite and least favorite question, I have to say. It's definitely the question that I get asked the most. And it's also, I think, the hardest question to answer. And what I normally tell people is that I really wish that I could tell you the answer to that question. Like, the question I get most frequently is like, what am I going to look like in 5 years, in 10 years, in 15 years? And the truth is that if I ever answer that question in a specific way, and this is what I tell the patients too, if I ever gave you an answer to that question, I would be making it up, because there's no way for me to look at somebody today and know what they're going to look like in 5 years and 10 years. The general our general understanding of Parkinson's is that it's a very slowly progressive disease, which means that it is a disease that tends to get worse over time, but it usually happens in a very slow way. Unfortunately, as of today, right now, we don't have any medications that can cure Parkinson's or that can stop it from progressing. Although there has been some research, there's a lot of medications, first of all, that are currently in clinical trials looking for this exact question. So I'm very hopeful that we're going to have an answer for that soon. The other thing is that we have some data now that exercise might slow down progression. So the one thing that I really push hard on all patients, regardless of what stage of the disease they are in, is that they try to exercise as best they can to the best of their ability. Because, and I think even our current understanding of what progression looks like, most of that data is coming from before the time that we recently kind of discovered the benefits of exercise. So I think even our current understanding of Parkinson's might change in the next few years once we can incorporate more data about what we know about the effects of exercise.
Yeah, and kind of again related to progression, have you noticed any sort of I guess veterans generally who, let's say they were in Vietnam exposed to Agent Orange, like have you noticed among your veteran population that their progression is different than that of the general population?
That's a really good question. I have to say, I don't know about any specific data that has looked at that, although I think it's a really important research question. But I have to say that when I just think kind of anecdotally about my patient population, I don't notice a significant difference.
Okay. So it sounds like exercise may be the most important thing. If progression is a concern, which I know it is because Parkinson's is progressive neurological disease, it sounds like exercise is probably the best thing that you can do. And for those of you guys who are not exercising currently, the Parkinson's Foundation can definitely help connect you to a local fitness program, even a Parkinson's specific fitness program that can really try to address sort of the more unique needs of those living with Parkinson's. And so Dr. Shpiner, kind of going back to building a care team, as you mentioned during your presentation, there are lots of members of this Parkinson's care team because there are so many different systems of the body can be affected. So what would you say, it sounds like starting with your general practitioner neurologist is a great place to start when you're thinking about building a team. Generally speaking, are you the one that would have to refer a veteran to speech therapy or physical therapy, or how does that work through the VA system?
Yeah, so I frequently refer the patients myself. Referrals can come from their general practitioner as well, but I also frequently make those referrals.
Okay. And is something like, and I know it just depends on the individual, but do you typically, physical therapy, I think, and we'll get more into that later on in the discussion today, but I know physical therapy is one of those therapies that often, I think, people wait until they're having an issue or an impairment manifests or something before they see a physical therapist. But would you say that a good rule of thumb is if you have a movement disorder that you probably need to try to get into a physical therapist sooner rather than later?
Yeah, absolutely. And I think also that, there's kind of two categories of patients I think that are like the best candidates for physical therapy. Although honestly, I'm really happy to refer any Parkinson patient to physical therapy at any time. So I'm very liberal with my physical therapy referrals. Anybody who wants to go, I'm willing to send them. But I think that two kind of really important times are right at, maybe around the time of diagnosis, especially if it's somebody who is not really active, not really already in an exercise program. I think that physical therapy is a really good place to start, because that therapist can kind of evaluate the patient and determine what the needs are and help them develop an exercise program that's going to be appropriate for their needs. And then the second time is kind of around the time that patients start having a lot of significant problems with balance, because right when you're kind of progressing to that stage where you're starting to have balance problems, is a time when people are really starting to become higher risk for falls. And my personal experience is that it's actually a higher risk for falls than people that are pretty more severely affected by their symptoms, to the point where they already know they have balance problems, they're already using a walker, they're already using a wheelchair. Those people are high risk for falls, but they're aware of their limitations, and so they're more careful. But people that are just starting to have those balance problems are really starting to become higher risk and may not be aware of all their limitations. And so that's also a really important time that I found that I like to have physical therapy on board.
That's great. And I know another question kind of related to building your care team is, it's fantastic that all these resources are out there, all these specialists are out there. But as, let's just say a veteran in the VA system, do you have really access? I mean, no matter where you live, would you think that it's safe to assume that you would have access to these services, that they would be, covered as part of your benefits? If you could kind of speak, and I know it's very different, probably depending on the person and the situation and, your status, I guess, when you're discharged, but could you speak to that a little bit, just briefly?
Sure. So I think, so I have to preface this by saying that I'm definitely not an expert in benefits through the VA, but one thing I think that the VA does really well, and I feel like I have a good perspective on this because I work both inside of the VA and also in the private world at the university. One thing I think the VA does particularly well is the integration between the different members of the team. So I think it's really easy for me, for example, to send somebody to see urology or cardiology. And first of all, I always receive the notes when I refer patients, which doesn't always happen in the private world if it's somebody who's like seen outside of our system. And I also have a good way of getting in touch with those people that have seen the patient, or copying them on my notes, or sending them an email, or sending them a message. So I just feel, so in general, I feel like at the VA, it is definitely very easy to refer to the different services that I need, and also to have good communication with the other professionals that have seen the patient.
That's great. And that's a really important, point, I think, especially given that your care team could consist of so many different individuals. It sounds like if you're in the VA system, there's a much higher likelihood that those individuals will be talking to each other and working together and sharing notes to ultimately give you the best possible care. So that's a really important point. So kind of a departure, but somebody is asking about DBS, deep brain stimulation, and they want to specifically know if it provides relief and control of symptoms beyond tremor.
So that's a really good question. So in general, there's kind of two types of patients in the Parkinson's that are good candidates for DBS. So number one is somebody who has very severe tremors that don't respond even to very high doses of medication. The second category of person is somebody who has a good response to medication, but the medications maybe aren't lasting very long anymore. So we know that over time, medications in Parkinson's, patients tend to need higher doses, and they need to take the medications closer together to get good control of their symptoms. I also want to highlight one thing that is a rumor that I commonly have to address in clinic, which is that it's not because the medicine stopped working, it's because the disease is continuing to progress. So underneath the medicine and the great symptom control that you have with the medicine, the disease is still there and it's still progressing. So patients who have a good response to medicine, but are requiring their doses very close together and may have a lot of ups and downs during the day or wearing off time, those are also patients who are typically good candidates for DBS. So the main symptoms that get better with DBS are the same ones that get better with medication. That's kind of the general rule of thumb. So the general ones are stiffness in the muscles, slowness in the movements, and the tremor symptoms. Walking is kind of so-so. So generally speaking, if your walking gets better when your medication, when you feel on and your medications are working, there's a pretty good chance that it's going to respond to surgery. But if your walking is still bad, even when your medication, when you're on and your medications work, it may not respond to surgery. So those are kind of the general principles.
Okay. And is DBS something, like, to your knowledge? I know we don't want to spend too much time on benefits because you said
Sure.
that's not your area of expertise. But we'll share a phone number and the VA website that we have on our Parkinson's website in the chat here in just a moment, so that if anybody does have questions about their specific benefits and coverage, that they can call that number. But is DBS typically something that, to your knowledge, is covered by the VA, or do you?
So again, without being an expert on coverage, I would have to say that I have many veteran patients that have had DBS, and I am not aware of anybody who was otherwise a good candidate and interested in getting it that could not get it because of coverage problems, if that answers the question.
Yeah, absolutely. That's really helpful.
Yeah.
Okay, this next question, let's see. How do you convince your care team members that the complexity of Parkinson's treatment requires clearly written treatment goals that are communicated among all team members?
So how do we like make sure that the goals are?
Yeah, it sounds like this individual, it sounds like they're working with a care team, but they are having a hard time getting their care team members to communicate.
Okay.
And to kind of work together on some of their treatment goals. So would you say, yeah, what do you have any recommendations for that person? And I don't know if they're referring to, within the VA system or outside the VA system, but I don't know if you have any suggestions from a neurologist standpoint.
Sure. So I think the best people to kind of coordinate all the recommendations are either your neurologist and or your primary care doctor. So I think if it's difficulties with coordinating recommendations among different physicians on the team, maybe, for example, the one thing that I can think of for an obvious example that comes to mind is sometimes we have trouble in Parkinson controlling blood pressure, right? So sometimes people have a lot of difficulties with fluctuations in blood pressure that can cause, they can have drops in blood pressure when they stand up, and then they can feel dizzy, and Parkinson medications can exacerbate some of those symptoms. So sometimes what's required if we're trying to optimize Parkinson medication to control tremors, for example, and we start causing problems with dips in blood pressure, the solution for that is not to stop the Parkinson meds, it's to reduce maybe other blood pressure medicines or other medicines that could be involved in dropping blood pressure. So your neurologist probably isn't going to feel comfortable telling you, okay, why don't you stop your, your blood pressure lowering meds. So probably if you're getting different recommendations, say your cardiologist like really wants you to be on this blood pressure medicine and your neurologist wants you to be on this other medicine for tremors, and those medicines maybe are interacting and working together to make your blood pressure too low, probably the best person to figure out what to do with those meds is going to be your primary care doctor, because that person is kind of the expert at all the different problems and also at kind of integrating the recommendations from all the different specialists, if that makes sense. So if it's a medical issue or something like that, where you're getting recommendations that are directly kind of competing with each other or, causing medication interaction problems, I would say primary care is the best person to direct that care. If it's more directing recommendations, I guess, from like physical therapy or, things that are more specific to the movement symptoms of Parkinson's, I would say probably the neurologist is going to be the best person to coordinate that.
Yeah. And my mom, who has Parkinson's, I think I thought she clearly explained it to me that her primary care is, you think about them as like the quarterback, right? Mm-hmm. They're kind of, coming up with the plans and keeping track of it all and making sure that everyone's on the same page. So, well, that's great. And then speaking of medication, this individual, and again, this isn't, as much related to the care team, but I think it's a question that often comes up, and it has to do with, is there a concern of taking Parkinson's medication too early in your disease? Is there, this person, I think, was concerned that their neurologist started them on medication too early, ramped them up too quickly, and now they've had dyskinesias as a result. So I don't know if you can
Okay.
speak to sort of that medication question.
Sure. So we used to have this idea that when we started specifically Cinemet or levodopa for Parkinson's, that we were going to have like a set window of time when it was going to work and then it wasn't going to work anymore. So sometimes, neurologists like in the past would try to kind of time the start of the medication based on like, what else was going on in the patient's life, and they might try to delay it. But now we know that that's really not true. It's not that levodopa, again, like I mentioned before, it's not that levodopa stops working. It's that this disease progresses. And so you may require more to control the symptoms that you have. So now keep in mind, like I mentioned before, that none of the medicines cure Parkinson's or affect progression. So the medicines that we have are for the symptoms of Parkinson's only. And so the decision of when to start medicine and how to increase medicine and how to adjust medicine should really be based on the symptoms that the patient has. So when I approach this question with patients, I always kind of come back to the same thing, which is, how well do you think your symptoms are controlled? What are the symptoms that are bothering you? Do you think that the medicine is controlling the symptoms, or do we need to make adjustments? So I don't know if that answers the question, but always the decision about when to start medicine and how to adjust medicine for me is based on the symptoms that are bothering the patient or affecting their ability to perform their normal activities.
That's great. Okay. And unfortunately, we are just about out of time. So I'm looking to see if there's one kind of final question. Yeah, so I think we always want to end on kind of a positive note, right? So going back to exercise, exercise. We talk all about it. I know we even have a book called Fitness Counts at the Parkinson's Foundation. We have new exercise guidelines that were recently released. But as a movement disorder specialist who is obviously a big advocate for exercise, can you share what would be an ideal exercise routine for someone with Parkinson's?
I think that's a great question. I think some of the earliest exercise trials that we had that were showing impacts on progression really focused a lot on like cardio exercise, or exercise where people were able to elevate their heart rate and keep it elevated for a set period of time, and then doing that on a regular basis. So I have to say that initially, once that data came out, I was really pushing cardio exercise on people. But currently what I use, and I will actually push this back to you at the Parkinson Foundation, is there's that 1-page handout that gives like a general recommendations for exercise for Parkinson's, and it kind of tells you, and that's actually my go-to reference. I actually have those printouts in my clinic, and I give them to patients that ask me about, what kind of exercise routine should I be doing, because I think it gives you a good breakdown of how many days per week you should do of stretching, or how many days of weights, or how many days of cardio, because I think this is kind of intuitive, and I don't think there's any strong studies to support it, but I think we all kind of know that probably the best exercise routine is like going to be a blend of different things. It's going to be a little bit of stretching, a little bit of weights, a little bit of cardio. So I think some kind of blend of all of those is ideal. And I like I said, I use that Parkinson Foundation handout frequently in my clinics when I have this conversation with patients. And then the other point I just want to make on that, and this is also something I tell all my patients, is that with that being said, the best exercise for any individual is the exercise that they're going to stick with. So, and be willing to do on a regular basis, because even if and I use this example too, because I personally, I like to exercise, but I hate running. So even if I told somebody that there's a study that says that running is the best exercise for Parkinson's, if you hate running and you're not going to do it, it's not going to help you. So I think probably the best exercise routine for any individual is something that they enjoy and that they're actually going to be able to stick with for the long term.
That's great. And we'll try and touch on some more specifics in the expert panel as well. I know we had a few questions about, does the VA cover gym memberships and things of that nature? So we'll try to get some of those questions during the expert panel. But I also want to highlight, my colleagues put a link to the exercise recommendations in the chat. So definitely click on that. You can print out these recommendations. Just know that if you have any questions about actually how to use those recommendations, you can contact our helpline. Again, they're not meant to overwhelm anybody, but really meant to be a guide and kind of a motivator as you're navigating exercise. So Dr. Shpiner, wow, thank you so much for your time today. You've been amazing. Thank you so much for just the way you were able to really communicate some of these important points and a way that I can understand, and I'm sure many others. So thank you, and thank you for what you do in taking care of our nation's veterans. So we appreciate your time. And now we are going to kick things over to our expert panel. So now that Dr. Shpiner has sort of introduced who these members of our care team might be, we're actually going to hear directly from some of those members of the care team. So in order to do that, I want to first introduce our expert panel moderator, Dr. Vanessa Hinson. Dr. Hinson is the Chief of Neurology at the Ralph H. Johnson VA Medical Center in Charleston, and a professor of neurology and director of the Parkinson's Foundation Center of Excellence at the Medical University of South Carolina. Dr. Hinson helped spearhead the Parkinson's Foundation's very first veterans program. We had over 1,100 people joining us, which was very exciting. So Dr. Hinson is obviously very knowledgeable and a fantastic team member. And we are just so grateful that you're here today, Dr. Hinson. And I know that you're going to briefly introduce our other panelists, and we're going to get to it. And just a reminder, if you do have questions for the panelists, please keep them coming. Keep submitting them through the Q&A icon, and our team will be trying to get to as many of them as we can during the last 15 or 20 minutes of the program today. So thank you.
Thank you for the introduction, Annie. It's really great to be here, and it's really fun to do another webinar specifically for the veterans. So thanks for putting that together. And Dr. Shpiner, this was an absolutely outstanding talk, and I think we will recruit you to join our VA in Charleston. So be on the lookout. You're absolutely over the top. Now, let's talk about our panelists today. Annie, could you make sure that we have our veteran, Jim Rhodes, and his wife, Carolyn, his caretaker, on the line? I don't see them in my panel, or there they are. Hi, Jim and Carolyn. It's really nice to have you. So let me introduce you to our participants of the webinar. Jim Rhodes is a veteran, and Jim has Parkinson's disease, and we are very grateful that he has volunteered to share his experiences firsthand with us. And his wife, Carolyn, is not only his support person, but she is also a therapeutic exercise specialist and a fitness director. So we've talked a lot already about exercise, but she can probably add some more points to that equation. And they're joining us from Huntsville, Alabama. Next, we have Sean. Sean, raise your hand. Sean Catalinas is an occupational therapist. He's one of my colleagues at the Ralph H. Johnson VA Medical Center in Charleston. And he's a really important member of our interdisciplinary care clinic that we have in place for Parkinson's disease. Jennifer, hi. Jennifer Pace, she is a speech and language pathologist and an integral member at the Charlie Norwood VA in Augusta, Georgia. Hi, Jennifer, and thank you for joining us. Dr. Christina Catron. She works with me also in Charleston at the Ralph H. Johnson VA. She is a nurse practitioner, and she coordinates our interdisciplinary clinic at the Charleston VA and has a special interest related to mental health care related to Parkinson's disease. And last but not least, maybe even most important, because we've gotten so many questions already related to VA benefits, we have Tara Jones, who is a veteran service officer with the Louisiana Department of Veterans Affairs, and she helps veterans access the benefits that they so well deserve. So welcome everybody, and thank you again for joining us for this important segment of the talk. So let's start with you, Jim. You're going to be the center of our attention in this panel, so make sure you're unmuted and stay unmuted for a good while here. We met a little bit yesterday, and you shared some of your journey with me. And you shared that you were diagnosed with Parkinson's disease back in 2016 when you noticed that your left hand was starting to shake a little bit and you would develop some trouble with walking. And just share with us what that diagnosis meant to you at that moment. Somebody, said the big word Parkinson's disease, or maybe they just said two letters, PD. What was that feeling like to hear that from your doctor?
It was scary. It was depressing. It was, I felt that, oh my gosh, I'm the only one with Parkinson's disease. And, but on the other hand, my wife and I started, we were looking at a Leslie Stahl video of that a couple people had told us about this rock steady stuff. And I said, you know, isn't that how Muhammad Ali got Parkinson's, by boxing? And they said, well, you don't hit each other. And I said, well, okay. And we watched this video in our airport in Charlotte, where our daughters live. It was about 2 weeks after my diagnosis. And I said, to turn to Carolyn, I said, we got to do this. We got to do this. And we were certified in April. And we started our Rocksteady program here in May with 6 guinea pigs, as our head coach called us, because they didn't know how to do this. And it's been amazing. So, 28 volunteers. And 28 volunteers.
So you really took kind of immediate action, right? You received a diagnosis and you were looking for your tool, which was exercise and specifically boxing in your case, to turn things around. Now, some patients ask me sometimes, I've never exercised in my life. How should I change my habits? Are you someone who has been an athlete all your life, or why did you choose exercise as your tool to combat Parkinson's?
I've not been an exerciser. I've been active in camping and other stuff, but I've not been a typical exerciser other than when I was in high school and in the Army. But and that was a brief period of time. That was 3.5 years. So back in the 70s, 60s, and I don't know. I think I wanted to fight the disease. I wanted to fight the causes of the disease. And I wanted to, maybe I was in denial, but it certainly helped me tremendously with the camaraderie in the program, fellow boxers. And we have people from 40 years old to 93 years old in our program, broken down into different categories. And I'm not only a boxer, but I'm a coach, and which I'm the only other 2 of us are coaches that have Parkinson's. The rest are all 13 coaches are non-Parkies. So
yeah. So that's, and I think the take home message here is, number one, already early on in our panel, you don't have to be a habitual marathon runner, right?
No.
To make Parkinson's a reason to now exercise. And I think your story is so telling. You did not come from that background. Yes, you're married to someone who is an exercise specialist and a fitness director at the local senior center, and maybe she helped you just a little bit get motivated. But I think that, you can change your habits to make exercise really a center of your care. Now, Carolyn, we already said your life also involves around exercise and fitness professionally, but you've been really engaged with the Boxing for Parkinson's program, and you've met so many people who have Parkinson's who are boxing. Beyond the exercise aspect, your husband already alluded to that. Tell me what your understanding is, how people benefit from the whole package deal.
Well, we started, we assess the boxers early on. And so we talk a lot. We've had over 400 people in our program. So I've learned a lot. I feel like a Parkinson's expert before I ever wanted to be one. But I mean, we just see that whole package. It just makes them feel better. We bump each other back and forth to our Parkinson's care clinic for physical therapy. So we've just seen the whole person come out, because we do the voice exercise from Speak Out and Loud in our group with Rocksteady. We've got, we just kind of try to treat the whole person. They all want advice. They all the care partners want advice. We've got groups for them. And so I'm not sure if I answered your question, but that's what
absolutely. And then Jim pointed out the camaraderie, right, that goes along with it. You kind of hanging out with some people outside of the hospital world and appointments and so on. So such a good experience.
Just 3 weeks ago, I started a grief share. We've lost 47 boxers in 5.5 years. And it just occurred to me in my sleep, like all this other stuff, that these people needed a place to come to, because once they don't bring their spouse anymore, they're by themselves. So we have a dozen that have been interested, and some of them lost their spouse as long as 2 years ago, and they came too. So that's a weekly group with an expert facilitator who does this regularly. So
absolutely wonderful resource you have available there, and deeply needed. Absolutely. Let me bring Sean into our conversation here. Again, Sean is an occupational therapist, also closely works with our physical therapist at the Charleston VA. And hearing Jim and Carolyn speak about essentially community-based exercise, Sean, can you explain to our audience how that differs from kind of prescription, occupational and physical therapy referrals? When should I choose to go to the community and exercise on my own? Or when would I be better off getting a prescription from my physician for therapy with you or a colleague?
Yeah, that's a great question. So a community-based program like boxing or another exercise class, I would think, it's a great resource for someone to be able to be engaged in a formal exercise program and stay active. It would be great to supplement therapy or sometimes even just on its own. And as we've heard many times already, exercise is very important in the management of PD, and the community-based programs are a great support, which we're hearing about now. However, sometimes these programs don't have the resources or training to offer more individualized interventions for a patient that may have very specific deficits. And that's when, it would be a good idea to see a OT or a PT. And I'm just going to kind of talk about more of a formal therapy intervention. So in a more formal therapy setting with an OT, we would evaluate a patient's upper extremity musculoskeletal range of motion and strength, as well as their sensory functioning, their hand and wrist range of motion and function, as well as the patient's ability to complete his or her activities of daily living. And we are also trained to be cognizant of a patient's mental health needs as well as their cognitive status. When evaluating a patient's ability to complete his or her activities of daily living, OTs can provide a patient with specific adaptive equipment to make them more successful and guide a patient through remedial strengthening or various compensation techniques. So I think if it, like we kind of talked about in the beginning, if a patient is just recently diagnosed with Parkinson's, I would probably say, go ahead and let's evaluate them, either both PT and OT, and kind of get a baseline, kind of see what we could do to increase safety and maintain independence, whether if that's strengthening or offering various equipment. So on the other side of things, a PT would be able to evaluate a patient's lower extremity musculoskeletal strength and range of motion, as well as balance, and possibly provide a walking aid, a rolling walker, rollator, or a U-step. And we know that U-step is a device that helps people with Parkinson's be steadier while walking. So we offer outpatient here at our facility, as well as if a patient doesn't live close to our facility, we do offer community-based therapy. And then I know they wanted me to talk about the LSVT Big as well. So we do offer LSVT Big. This is a specialized amplitude-based exercise program to help patients improve the quality and size of their movement. So this is a more structured exercise program that could be run by a PT or an OT. And the VA does offer this, whether it's through an actual VA building or if it's through in the community as well. So that was a lot of information, but I would always recommend if a patient has a change in status, whether it's a fall or something, or a hospitalization, it was probably a good idea to be, reevaluated by therapy and kind of just see what we could do to help maintain that level of independence.
So really what I hear you saying, Sean, is it would be a great idea to get a baseline evaluation early on to see where your strengths are and where your weaknesses are. And then later on, as you kind of cruise as a Parkinson patient, if there is a setback, like you say, a change in functioning, a reevaluation would be really important. Jim, did you ever go through the program that Sean is mentioning that we refer to a lot as Parkinson experts, that's called LSVT Big? Did you ever go through that in Huntsville?
What?
do speak out.
Speak out.
You did the loud program, right?
Yeah.
Yes.
But I have through our multidisciplinary clinic here in Huntsville, started by Erin Edmondson. I've gone to PT, OT, speech, and nutrition. And I go to them routinely because I want to stop what my issues are. So I'm going to PT right now because I have problems getting off the ground, and she's working with me on that. But I've gone over the years for slowness of movement, rigidity. Carolyn makes sure that as soon as she sees something going on with my Parkinson's, that she said, it's time for PT. So
Yeah.
And we do the big movements in our Parkinson's class because the director of the PT clinic is one of our coaches. So she brought in those big movements and Jim uses those as their warm up.
Yeah, I use those as my warm up for my class.
Yeah.
So
Yeah.
So
That's great. So it sounds like you already have that knowledge in your classes. So for people who have no idea what we're talking about with this big business, so with Parkinson's, not only are people slowing down with their movements, but if you will see, the movement amplitude kind of gets really small as well. So people, as you know, start shuffling, take shorter strides, but overall the whole movement amplitude decreases. And so the big program tries to counteract that tendency, also the kind of the hunching over, redeveloping a big posture. And it's a really time-intensive program for 4 weeks. You're really into it for 4 times a week. But after that, you graduate and you really see a fairly immediate benefit. As Sean is pointing out, you can get it either at your local VA, if the VA is certified, or you can ask for a community care referral. And there are databases where your physicians can find somebody in the community who is certified. And this is very commonly throughout the country now available. So we recommend that. It can be either done by a PT or an OT specialist. Sean, let's get back to what Jim was just saying as an example to keep this practical. He was mentioning trouble getting up off the ground, or maybe even trouble getting up off the bed, anything to pull up. Some people feel like they're stuck in their bed. Give us some examples of equipment or tricks or things that you would work with Jim on in that regard.
Yeah, so probably with him, we would look at what kind of equipment we could add, maybe to the side of the bed, a rail. A lot of times we'll do a rail that kind of goes to the floor and goes under the mattress. That's stable and could kind of provide an anchor for you. And then if we look at kind of more strengthening, we would focus on probably the PT would focus on some lower body strengthening and kind of techniques. A lot of times I see that they'll actually have the patient on the floor and work on using a chair nearby or something like that to actually, let's practice this situation. So if this does happen, let's kind of know what the best next steps are.
Yeah,
that's right.
That would really be very, very helpful to many veterans. Jim, you were also alluding to another program called Loud, and that brings me to kind of a little bit different chapter of Parkinson's symptoms. Not everything is evolving around tremor and walking and balance and getting up. Some evolves around the voice and communication. Can you share if you have had issues with your voice and what has been frustrating you in that regard and what therapies you have sought out? And then we'll get Jennifer to chime in as our speech and language pathology expert on the panel.
Okay, I had trouble swallowing. Have had trouble swallowing. I had what is it? Dysphagia.
I guess.
Yes.
Well, because you had a brain bleed.
Yeah, brain
right.
bleed. But from my DBS, and so my speech therapist has taught me to speak with intent. And I go weekly to Loud Crowd, and I participate weekly in that, and it has made a big difference in my ability to speak and to speak clearly, and with intent. So, and I'm not choking like I used to.
So he did Speak Out and Loud Crowd, which is different from Loud and LSVT and so forth, but mostly with the weekly maintenance that we do. So we have several groups that do that.
Yeah.
So Jennifer, listening to Jim's experience and the fact that his loud crowd is called loud and has the word loud in it, can you describe a little bit the voice changes that you as a specialist in voice disorders are experiencing with your Parkinson patients and how you treat them? And then we'll get to the swallowing chapter next.
Absolutely. So the changes that as a speech pathologist, we try to take care of are things like the loudness of the voice, the level of intensity, how loud you're able to speak, the clarity or intelligibility of your speech, and sometimes the rate of the speech. Sometimes that rate becomes increased with Parkinson's disease. There are a couple of different specialty programs, if you will, and Mr. Rhodes, you spoke about one of those in particular. I'm going to talk about that a little bit, as well as the LSVT, which I'm certified in. The two primary, very structured programs that speech pathologists use to treat patients with Parkinson's with regard to voice are LSVT Loud and Speak Out. Both of them are very structured, and in both of those, you're evaluated initially by a speech pathologist. There is a very prescribed manner in which you have those initial sessions with your speech therapist. And then there's also groups outside of the speech therapist so that you can have carryover and maintenance for years to come, if you will. And like I said, both of those programs have those opportunities out into the community. It sounds like you're experiencing good success with the program that you're using, sir. There are a couple of other options I can speak of too. In some patients, we can recommend a referral to an ear, nose, and throat doctor, and they may possibly have what's called a vocal cord injection. Sometimes that helps not just with the voice itself, but in some cases it can help out with swallowing. Another device that I've actually gotten a good number of referrals for more recently is called a Speech Vive, for anyone who is, and essentially what that device does is provides background noise, almost as if you're in a restaurant type of environment, and tries to kind of trick your brain into speaking at a louder level. It kind of just looks like a hearing aid that fits on the back of the ear.
Yeah.
Jennifer, this is Annie. We're just going to mute you and connect you through your phone. If you don't mind just putting your cell phone to Krista in the chat, the audio is cutting out a bit. So we'll come back to you if you don't mind.
So we'll come back to Jennifer in a second. In the meantime, let me ask Jim and Carolyn about the other problem we'll discuss now, which is the swallowing issues. So Jim, is that swallowing pills, or do you cough when you drink liquids? What are your issues with that?
Both when I swallow pills and when I drink liquids. But it's better now. It's much better now.
Right.
But there was a time there where I was, every time I drank something or took my pills, I coughed. And,
yeah.
So they did the fees test and did a lot of work with them.
Right.
For the first,
Did
12
that
days.
make you nervous, Carolyn, that you might potentially have to do the Heimlich maneuver on your husband?
I didn't see, it wasn't that bad, actually. So he would just come and tell me. These are things that were kind of silent, He would say, when I'm taking my pills, I'm having a hard time.
Yes.
I still work full time, but when we were home at night, he would do it a little bit, but it was more during the day. Yeah. So I didn't see a lot of it. And it was very, very minimal when he started going, which I was really proud of him, because we're trying, when we came into this Parkinson's deal, we see all these little shufflers, I call them. And so all the things that they have problems with, and we see him doing that much of it, he goes to therapy for whatever it is. So we didn't
so you're addressing your challenges early, it sounds like, before they get out of hand. Yeah.
Really didn't let it get very bad, because we knew.
So Jennifer, are you back on your audio? Yes. No. Okay. All right. We'll come back to you later, but we really want to address that, because I think a good piece of advice, if you have any trouble swallowing, to get referred early to a speech and language pathologist for that before you start aspirating and things going down the wrong pipe. So let me get to a different issue here altogether. Dr. Ketron, nurse practitioner at the Ralph H. Johnson VA Medical Center and part of our big and active interdisciplinary clinic. What we have not talked about at all today yet is the issue of mental health symptoms related to Parkinson's disease. And as we're talking about building our comprehensive Parkinson's disease care team, I really wanted you to weigh in from your experience. How common are those symptoms, and how, as a director of such an interdisciplinary clinic, how do you address them?
Yes, thank you. It's a great question, and very important question too. When we think about Parkinson's, often we think about, the loss of dopamine being something that we talk about and how that affects movement, but also it affects our mental health. Dopamine, in a simple term, is the feel-good hormone, and so it can affect our cognition. It can affect, our ability to want to get up and do things and be active, and our concentration and attention, and it can affect our mood. So when we think about the whole health concept that the Parkinson's Foundation, the VA in particular has, whole health is encompassing all the things that we talked about today. And mental health is one of those things, and it cannot be pulled out separately. We really have to incorporate it because it affects every area of your life. And so some of the symptoms that we see, depression being the first thing that we'll talk about, and that can actually be an early sign of Parkinson's. People that may present with what we call a masked face, people may think that they, are you depressed? Why are you not smiling anymore? And that may be one of the first conversations that you have, that there may be some changes. So depression can be common, greater than 50% of the patients with Parkinson's, and even really higher than that we see sometimes. Within the veteran population in particular, we know there are other comorbid, mental health issues that we see, such as, post-traumatic stress syndrome. And so that's something that we want to evaluate, and also, treat that as well. So that may be completely separate than what's going on with the depression that may be resulting, from the Parkinson's itself. Anxiety also is a symptom that we see. It can be just the illness anxiety that, we're worried about the disease progression. We're worried about how it's going to affect our lives, our family, maybe our jobs if we're still working. And so that's something that, is really important that we talk about. There's apathy. Apathy is different than depression, but it can be really hard to kind of tease those two symptoms out. Depression is, usually we see, a lack of motive, desire to get up and do things. And, there's sadness and worry that comes along with that. And maybe you change some of your activities because you just don't, you don't feel good. You don't feel like doing those things. Apathy is, you may not be depressed, but you just don't have the motivation to get up and do anything. And we see that very common in Parkinson's also. So what's kind of can be difficult with both apathy and depression, and even anxiety, is that it can prevent you from getting up and doing those things that you need to do, like exercise, which we've all mentioned. And so you may want to go exercise, but you just don't have the motivation to get up and go to rock steady or, any of the other activities that you're participating in. And then psychosis and hallucinations are something that we can see also. And those are really important that we address in the care setting and with other care specialists that we have with our team. And that's something that we want to treat if we feel like that hallucination is bothersome, and we want to make sure that we are, providing safety for that patient and caring for them. With all of these with all of these symptoms, whether it's depression, anxiety, apathy, or, some psychosis, specifically with anxiety and depression and apathy, we can use cognitive behavioral therapy to work with that patient in a therapy setting, where we talk about, different things that they want to do and how that they perceive their illness or their disease process, and really support them with their, the thought processes that they have and behaviors that may come from those thoughts. And so cognitive behavioral therapy is definitely a research-based program that we can use with our Parkinson's patients. medications are something that we can use for anxiety and depression and even psychosis with hallucinations. We do have to be careful with some of those medications as they can worsen Parkinson's symptoms. But when you work with your care team, we can evaluate those side effects that may occur and educate you about those. And then, of course, there are antidepressant medications and anti-anxiety medications. We like to work with a concept called behavioral activation, and that's just keeping a routine and saying to yourself, I'm going to get up and I'm going to exercise 30 minutes every day. And even when you don't feel like, and the apathy seems to be overwhelming you, then having that routine is you check it off your box. And the goal is that we feel better whenever we have met a goal. And then I think it's always important that we talk about social interaction and isolation. And that's been so difficult with COVID. And we've seen such a change in a lot of our Parkinson's patients because of the lack of, the interaction that they have not had. And that is so important. But that can uplift your mood and help you with your depression. And, you can have a lot of anxiety when you're out in public and you feel like people are looking at your tremor. And so that can cause people to back away, from a social setting. And we want to encourage you to stay social. And then exercise helps with, our neurotransmitters too. It boosts our mood. And so we always want to encourage exercise when we're thinking about treating some of these mental health symptoms.
And then can you also comment, especially since you were highlighting the value of therapy, what I sometimes hear from my patients, especially those who have apathy, there's a constant struggle between the spouse trying to be the motivator and getting the patient or the person with Parkinson's to participate in boxing, to participate in PT, OT, ST, all these good things that we're talking about. And all they do is kind of bicker about it because it's so hard to get an apathetic person to be motivated. What do you think the role of marital counseling is?
So that's a great question. And I saw Jim pointing to his spouse just then. And so, we feel like often when we, leave an appointment, we did, have some marital counseling with, the veteran and their spouse, because it is important and it can affect, the marital relationship. The wife feels like, or the, husband feels like that, they're nagging all the time, whenever really they're just providing that support, that encouragement. And so I think marital counseling can be helpful to kind of have those conversations about, what is an acceptable level of, pushing in each individual, marital situation, or even the caregiver situation. It may be, another family member. But it is helpful to have those open dialogue within, with a therapist that's trained to help guide those future conversations and the changes that are going to occur as the disease progresses. It affects the patient as well as the caregiver. And it's really important that we look at all aspects, and, the marital relationship is part of that.
And I think that's another, Dr. Shpiner mentioned in her talk about how well she thinks the VA care is integrated.
Yes.
And that is certainly one real strong feature of the VA. But I really want to highlight that mental health provided through the VA is absolutely outstanding. And like Dr. Shpiner, I practice at the university in the private world and also at the VA. There is no better place to go for mental health care than our VA system nationwide. We have outstanding counselors. We have immediate access. In the private world, you're often on a wait list for 6 months. That is absolutely unheard of at the VA. And thank you, Dr. Ketron, for making those remarks and encouraging veterans to seek out therapy services. Jennifer, are you back over the phone with your audio?
I think so. Can you hear me now?
Yes, I can hear you really well. It was ironic to have the communication specialist have communication problems, but that's how life goes, right? Just wanted to quickly come back to you because as a physician, what scares me, it didn't scare Carolyn, but it does scare me a little bit to hear when I hear a patient say they have swallowing issues, I'm thinking, there might be complications, maybe they get an aspiration pneumonia or something like that. So I would refer them to you. And what would you do with a person with swallowing problems?
So there are a couple different routes that we may go with someone who has swallowing problems. And sometimes, as you indicated, sometimes that the patient is already having a problem. Some of our physicians will send someone to us on an annual basis, potentially to get ahead of any potential issues that may be occurring. As a speech pathologist, we like to talk to the patient and the patient's caregiver and kind of get some information on maybe what that individual is having difficulty with, if there's any weight loss potentially associated, with maybe selective diet, if they're avoiding some things in their diet that maybe they used to enjoy, or maybe they have decided that maybe they just want to eat soft foods. Then we may do some type of test to get a further look at what's going on with the swallowing. That may be something like just that, have someone eating, drink some things in front of us, as well as take a look at the different muscles used in eating and drinking and see if there's any difference with those than what we would expect. And then we may also do some other tests. One is called a modified barium swallow study. It goes by a couple of other names. Sometimes it's called a video swallow. I've even heard it called a cookie swallow before. But that is just an X-ray where the speech pathologist will give you different things to eat and drink under X-ray, so we can see exactly what's going on there. All of the things that we would give you to eat and drink have a mineral in it called barium, and that just shows up on the X-ray well for us. That is not a test just to see if someone's having something go the wrong way or not, but maybe what we can figure out in therapy to make the swallows safer. Another test that you may have is called a flexible endoscopic evaluation of swallowing. Kind of gives similar information, but there's a very small scope that goes in your nose, and you get to eat and drink while that's in there while we watch on a monitor to see what's going on. So some of those are some of the tests that we would do. And, we can do therapy with that, or we may recommend certain adaptive equipment that may make the swallowing better as well. Sometimes we do recommend changes in diet, but that's not our preference. We would like to see everyone eating and drinking as safely as they can.
That sounds
Any
good,
other
especially the
questions?
piece about the diet at this point of the day. We're all hungry for lunch. No, that really explains how you evaluate folks and what you can do. Thank you for that addition. And really the swallowing problems often are a sign that we are transitioning into a more complicated phase of Parkinson's disease, or maybe advancing Parkinson's. And that can be a point when our caregivers need additional support. Carolyn has, been absolutely wonderful supporting Jim over the years. But there was a little bit of a rocky phase, right, in Jim's career of a Parkinson's patient after he suffered a small bleed after his deep brain stimulation surgery, Carolyn, and suddenly your caregiving abilities were a little bit stressed. Can you talk about that experience and what needs you see for caregiver support?
Well, I do think you need support. I'm not the type to lean on other people because I always lean on Jim, so it was interesting to be able to not be able to bounce things off of him because he was really in a daze and confused for at least 2 weeks. So we just, called in his sister happens to live nearby us, and we've got friends that came. But I did mention yesterday to you, our kids came in at different times to help. It's interesting versus adult sons and daughters. Our son was like, he's fine, and the girls were like, a wreck. And our son's like, you're babying him. But anyway, it was tough because I had people in the neighborhood that would have stayed with him, but I knew them and he didn't know them. And we see that in our boxing program too. They're not comfortable with caregivers they don't know. So it was kind of a little bit of a little stressful. And he had homework from his speech pathologist he was supposed to do every day. And I knew his sister wasn't doing it with him. I just knew it. And he couldn't tell me, but I could just tell. So I would be like, if you're going to come, you have to do this, And she just wanted to baby him and feed him. And he needed to do lots of work. And that's why he's back now at 98%, I'd say. It was difficult. And especially, we don't live near all of our friends. We moved about 25 miles away years ago because it was closer to his job. So we were at the other end of town for many years. So all of our friends that would have dropped in all the time lived, pretty far away. So that was a difficult thing too. So
yeah, you brought up several important points, calling in family, but then family may not know about Parkinson's, friends might not always be available. Dr. Ketron, can you mention what the VA has in place to provide some caregiver assistance?
Sure. Briefly, we have what's called the Caregiver Support Program. And with that, typically, and specifically in our VA, we have a group of social workers that manage that program. So within the caregiver support, they will provide community resources for needs that arise. They will, provide VA resources that we as, providers and other clinicians may not know about, but the social worker has a lot of ins and outs to direct them. They also provide, information about support groups that we may not know about. And so reaching out to the caregiver support program can be done in a couple of different ways. One of those ways would be talking to your primary care, your neurologist or other provider, and asking them, I need some additional support and help. What do you offer? Another option is, that they provide educational resources. So they may, refer you to the Parkinson's Foundation, for information. And then the other thing within the caregiver support is a program that just recently launched last year. And that is, it's also called CSP. So it is a program that is specifically for patients that are at least 70% service connected, and that served within the Vietnam era. So what that allows, you have to submit criteria, or you have to submit information for that, because there is criteria. And then there will go through a process of acceptance for that. That will provide financial means for maybe you to bring someone in the home to assist you as the caregiver. We've had several of our patients to be accepted into that program, and it's really helped the caregiver with their own mental health and supported the veteran as well. So that would be something that you would speak with your neurologist or your primary care about, and they would refer you to the caregiver support program.
What were the letters?
Yeah, go ahead, Carolyn.
C as in CS?
C. So it's caregiver support. So it's CSP.
Okay, got it.
Yes. It's a wonderful program, but they do have very specific criteria. So that's the reason why I mentioned the 70% service connected and serving in the Vietnam era. That's the first two criteria for that program. Then there's other criteria for that, and it relates more to advanced disease and what the caregiver is actually needing to do for that patient. And so you can speak with your social worker about that and see if you qualify for that program. A lot of people don't know because it is new. I think it rolled out last October or November, maybe in 2020. The last 2 years are a blur, but I do think that that's the time frame. And so it is new. And just to speak briefly about that.
It really has helped several of our patients significantly at the Charleston VA. And I think this is the perfect time to reintroduce Tara Jones, our Veteran Service Officer. And some veterans listening to this call, Ms. Jones might be thinking, I'm not even signed up with the VA, dial it back a little bit. How do I get signed up for VA care as a veteran? Can you start there?
Okay. Well, veterans, as in regards to, I work with disabilities a great deal, but as in healthcare, they would need their DD-214, and they would go over and fill out a 10-10D form, the healthcare form with the hospital. Yes. These forms are all, you can find it at the office with the patient advocate or like the social worker there in the clinic. But as in regards to the VA disability, veterans that have served in Vietnam, as you stated before, and veterans that have served in Camp Lejeune during a certain time frame, they are veterans that are subject to have been exposed to certain chemicals and toxins that are determined to be the cause of Parkinson disease later on in life. So they just have to show their DD-214, and we would file a claim for them. Now, based on what their diagnosis is, and then they would go through C&P examinations. The raters and the adjudicators would put them at a certain percentage. As Dr. Keaton said, there are certain percentages, you get certain benefits or benefits and medical things that come along with that. So over 50, 60, they get medical care and sometimes help with their medications. There is the caregiver program. It does have its requirements that the spouse would have to meet in regards to that. But We help in any state that the veteran lives in. There's the federal regional office, that's if that one is located close to them. But in any state, there should be a local veteran service office where the veterans can go in and see if they meet the criteria, or even search for their DD-214 to see about filing for any disability benefits that may apply to them.
Do you have to be receiving your primary care and neurologic care at a VA to be qualifying for this service connection?
No, ma'am, you can go to outside providers. That's if the veteran wants to utilize the VA healthcare system, if they want to try, but no, you can go to your private doctors and turn in your doctor's notes.
Excellent. So your private doctors could be filling out these forms that have lovely VA numbers and acronyms, and certify that you indeed have Parkinson's disease, which is very important. And then, as I think I understand from you, one can go to the veteran service officer at the local department, or a patient who's already a veteran seeing a doctor at the VA could go to their primary care doctor or neurologist at the VA, the social worker, and have that process set in motion, correct?
Yes, ma'am. Yes, ma'am. Correct.
Excellent. And then that would open the door to receiving
benefits. And the benefits, the compensation most definitely can be utilized to help to pay for help to come into the home to help with the spouses and the veterans, or however they need to for extra income.
That's good to know. Let me ask Sean, related to this, any of the equipment that an occupational or physical therapist would order, or even a PM&R physician, or let's say a wheelchair ramp, or something fancy like that, is that dependent on your service connection or disability rating? Any of that have anything to do with that?
I don't want to misspeak, but I don't believe so. I think, if the veteran is receiving care at the VA, we are able to get them what they need in order to maintain safe and a level of independence. I don't believe it has to do with service connection.
That's good to know. Okay. But still, motivating everybody who is listening right now, if you, served in the Vietnam era, or you were at Camp Lejeune during that time period, go ahead and file for that service connection. It's really important to have that in place, especially if you think about the caregiver program. And it sounds like that process is quite straightforward, right, Ms. Jones?
Yes, and Ms. Henson, as Sean said, no, if after you reach, a veteran reaches a certain percentage, it doesn't matter where they were located, the VA hospital will treat them. It's just that if veterans want to research to get service connected for the Parkinson, but once a veteran, say you have another veteran that is service connected at 100%, but that veteran has become diagnosed with Parkinson disease, the VA hospital still will treat them for the VA, and they can still have those benefits and programs that they can utilize.
Okay, thanks for clarifying that. That's good. So if any listeners in the audience have any questions for our panelists as they relate to VA benefits, or any of the therapies that we covered, or questions for Jim about his Parkinson's experience, please put them in the chat now. And it sounds like we have a question here for Tara Jones, actually, from a person who's saying, my husband is a Vietnam era veteran. Between my pension and Social Security, that puts us over the monthly threshold for VA coverage. Is my veteran with PD not able to get any help from the VA?
Okay. Well, some veterans, they're looking at it, they're applying for the incorrect, because there's the pension and there's compensation. So compensation would be based on the disability. So if the veteran is strictly applying based on where he served and his disability, then his income would not play a factor in applying for the benefit.
I see.
So he can apply. He can apply. So income would not have anything to do with that.
Okay, got you. That makes sense. Next question is going to Sean, our occupational therapist. And the question is whether an upright or an elevated walker is something that one could obtain through the VA.
Yeah, for sure. Ideally, you would be evaluated on that device, and if the therapist thinks that's the most appropriate device for you, we can provide that for you. They seem to be very popular right now. I think they're showing them on TV, so everyone wants an upright walker right now. But yeah, you could be evaluated, and if they find it as appropriate for you, we could go ahead and get that.
When would you think, what is a scenario where you would think as a clinician it would be appropriate to be asking for this?
Well, a lot of people, especially with Parkinson's, like the higher armrest because they feel like it keeps them a lot more upright, as the name implies. So, if they're doing okay with a rollator and they want that extra support higher up, I think that will be fine.
Yeah, yes, we see that a lot, that people have that stoop posture and really kind of like that unfolding, which in Jennifer's experience probably can also help kind of the voice, because if we're all hunched over and small, our voice is not going to project very well. And that brings me to the next question, which is addressed to Jennifer, our speech pathologist, and it asked her to talk again about Speak Out and LSVT Loud and how to access these services through the VA. And do you have to have a referral to get these covers, not just covered, but even performed through the VA?
Okay. As far as where to locate those services, each of those types of therapies, I think it's lsvt.org and probably speakout.org, each has the website, and you can go on there and look for providers in your area. That's probably the easiest way to access that and kind of see if that happens to be at a VA. If there is not someone at your local VA, then they may be able to send you out into the community for one of those providers to provide that service to you. As far as LSVT, I'll speak a little bit more about that because I'm certified in that and have been for quite some years, so I'm much more familiar with that program. It is very structured. It consists of 4 sessions a week for 4 weeks straight. And your end goal is carryover, so that you are doing the things in your everyday life that you're supposed to be doing with the voice that you would like to have. Okay, so the big premise of LSVT is speaking loud. That's what is emphasized throughout the program, is speak loud, speak loud. There are opportunities for carryover with that in a group setting, as we've talked about with the big program. There's similar programs for LSVT out in the community. There are also some opportunities online, different programs that you can do for continued home practice. With regard to Speak Out, it does not require quite as many sessions with your clinician. I think it requires about 12 sessions with the clinician. And then at that point, you're encouraged to find a program out in your community for continued group practice. I know that with COVID, because a lot of people were not able to go out into the groups as they had before, they've actually hosted Facebook programs almost daily so that patients can get practice that way instead of the groups as they were getting practice before.
Practice is so important. Don't put in the 4 weeks of hard work and then let it drop off. So thanks for motivating everybody to keep it up, essentially. Yeah,
Absolutely.
Thanks, Jennifer. Coming to Dr. Ketron with the next question, which relates to sleep and excessive daytime sleepiness, which are 2 areas that we have not talked about today. And the question is, who should a veteran address these issues with related to their Parkinson's disease?
Yeah, I actually have sleep disorders down and didn't get to that either. So with limited time, but it's a great question. You can speak with your neurologist at your movement disorder, appointment. You can also talk with your primary care physician. Sometimes, in our clinic, we will go ahead and treat the sleep disorder and then, refer out to, if the patient is needing maybe a sleep apnea test, a sleep study, which often can occur, that you have sleep apnea and that impacts your sleep itself. We know that REM behavior disorders can also be present within Parkinson's disease, and we treat those as well. So you can speak with your primary care, your neurologist, and then, depending on what we feel like is going on, we'll either refer out or go ahead and treat with medication. Sleep hygiene is really important. Making sure that you cut off all electronics, an hour or so before bed. But seeing if there's an underlying condition that's going on related to Parkinson's that's impacting your sleep is really important.
And exercising again? Yeah, we'll go to be
Exercising.
overusing this word, but since we are using the word again, sleeping is such a really important issue, daytime sleepiness, that can keep people from exercising. So the next question from the audience relates to the affordability of community exercise. And the question originally was, is this paid for by the VA? The VA does not pay for gym memberships currently, or the boxing program. But I wanted to ask Carolyn and Jim, because they have really outstanding community resources in their community home in Huntsville, Alabama, that sound quite affordable. Can you share a little bit about that and how you can get your community members to afford all this good stuff that you guys have going on there?
Sure. We've gotten support from a community health foundation. It's affiliated with the hospital, but it's not money from the hospital. It was seed money was put down by an individual. So we've received over 150,000 from them in 5 years, and we will receive it again this year, we're told. So there are things out there to help supplement. So we offer any scholarship. Anytime anybody says they can't afford it, we just say, can you pay a little something? Because those that we've given it free to have quit, believe it or not. So that's out there. And we only charge $40 a month. The average Rocksteady is $65 to $85. But we don't want to have anybody turned away because they can't afford it. I want to say too, because of something that you guys say, we also offer multiple programs. We offer urban polling, power moves. We're doing stretching and yoga.
Tai Chi.
Tai Chi. I have trouble remembering everything. I always have to look at my notes. So we offer multiple things because boxing isn't for everybody. So we're hoping to pull back in the 50 or so that didn't want boxing now that all these other programs are up and running.
So it sounds like it's worth asking in the local community whether membership could be reduced or whether there's, an affordable option. And I'm glad you're bringing up the Tai Chi because, and I don't know if every VA offers this, but Tai Chi is offered free for our veterans at the Charleston VA. So that might be worth asking because the VA is putting a great emphasis on whole health and, an integrated view of care. And Tai Chi is certainly part of that right now.
Yes, I wanted to state that most veterans can check with most outpatient clinics or hospitals, and the VA does. They offer mindful meditation as another panelist. They offer Move It. There's a Move It program, and I think there's even a Silver Sneakers program where veterans can apply and try to get exercise. Mm-hmm.
There are also in our community lots of options through the YMCA. There's specifically one that has obtained a community grant from the Parkinson Foundation. The Parkinson Foundation has been giving out grants to applicants who provide exercise services to their local community. And so sometimes the YMCA can be the recipient of such a grant. And so in our community, a lot of the Parkinson specific programs that Carolyn was describing are available through one of our YMCA. So it might be worth asking there also, since they can be quite affordable. Annie, give me a 2-minute warning when you want us to close this up, because I know you want to have some closing remarks. What I wanted to ask Jim to close this out for us on our side before Annie is adding her closing remarks is, if you had anything to say about your experience as a person with Parkinson's, the support that you've received from your wife, from the community, the positive things that you have experienced from your movement disorders care team, what would you say the take-home messages are to motivate other veterans to stay positive and look out brightly in the future of their Parkinson's disease?
Well, first I would say that you need, somebody mentioned quarterback, you need to be your own quarterback. So to develop the team around you, your movement disorder specialist, your neurologist, your general neurologist, your family practice, dermatology, because there's
97. What's the percentage? I want to say 97. I forgot the percentage. 7 times greater chance of having melanoma
Right.
if you are a Parkinson's patient. Go ahead.
PT, OT, speech, those that's the team. And you need to be able to communicate well with your local neurologist. Doesn't mean that you have to agree with them, but you have to be able to communicate with them. I think that your exercise program, doesn't matter what you're doing, the fact that you're getting off the couch and you're going out somewhere and doing an exercise program is so important. And my wife, Carolyn, has put up with me for 44 years, and she's still putting up with me. Our kids are so important to us. And I would say that Parkinson's has been a blessing in my life. And I know that's odd to say, but it is a blessing in my life, because I would have never met these wonderful people in our Parkinson's program, our 45 volunteers, and our coaches. They have saved my life. So I would, that's all I got to say.
You wouldn't want to trade his Parkinson's for any other disease. I love those words. But thank you so much, Jim and Carolyn, for sharing your very personal experience with Parkinson's disease. And thank you again to the rest of our panelists for adding their professional expertise to our discussion. We really value this. From my perspective, I only have one message for the veterans listening here: ask for what you deserve. There is every medicine for Parkinson's disease available through the VA. The services might be available, the therapy service at your local VA, and if they're not, you can ask for community care and you will get what you deserve. You can build your care team through the VA. So thank you again, and I'll hand it back over to the Parkinson Foundation.
Well, thank you so much, Dr. Hinson, for moderating, and thank you to all of our incredible panelists. We had so many questions that came in that unfortunately we just didn't have time to get to. So what I did put the VA's toll-free help hotline number in the chat. So please, if you have any questions specifically related to your service connection, benefits, coverage, compensation, disability, please do call the VA's toll-free hotline at 877-222-8387. If you have a Parkinson's related question specific to symptoms, treatment, medication, please consider calling our Parkinson's Foundation helpline, which is, I'm just drawing a blank here, sorry, 1-800-4PD-INFO or 473-4636. Thank you for putting it in the chat. I'm drawing a blank for some reason. You can also email our Parkinson's Foundation helpline at helpline@parkinson.org. So again, thank you so much to all of you for being here. We have a couple of slides we're going to get to, but I also want to remind you to please provide your feedback regarding today's program. Once our webinar Zoom window closes, an evaluation window will pop up on your screen. Please just take a couple of minutes to tell us what you thought about the program, and most importantly, what you'd like to see more of in the future. We are always working to try and reach more veterans with Parkinson's and to ensure that you have access to the education and resources that you're looking for. So please consider, again, filling out the evaluation. It really helps us out. Okay, and thank you again to Genentech, a member of the Roche Group. They are sponsoring the Veterans and Parkinson's virtual programs, similar to the one that you've seen here today. So we're really thrilled to have their support. And again, we're here for you. Please contact the Parkinson's Foundation for your Parkinson's related questions. And again, for any of your VA related questions about disability compensation and benefits, please do call the VA hotline. Visit our website as well, parkinson.org. And if you want to visit the veterans section of the site, you simply go to parkinson.org/veterans. So again, thank you so much for your time today. It's been a real pleasure. And again, another thank you to our presenter, Dr. Danielle Shpiner, as well as Dr. Hinson, our moderator, and all of our fantastic panelists. We are so grateful to have you here today and appreciate your service.